Chapter 18, Cardiac Function. Arteriosclerosis is a major disorder in the United States, and this gives you some background on the terminology. It was once thought to be a lipid disease, but now it is considered to be a result of an inflammatory process. Cardiovascular disease, acute coronary syndrome, all of these fall in the same category. The inflammation begins and the endothelium is disrupted. We have our white cells coming in as macrophages, and they secrete cytokinase, which will cause additional white cell adhesion. It's very sticky. It results in plaque buildup. Box 18.1 shows characteristics of an ideal cardiac biomarker. Particularly look at the third one. We want our markers to have absolute cardiac tissue specificity. They should be released from the myocardium following injury, and we want them to remain long enough that we can detect them, as we will often have patients presumed into the ER days after an attack. Table 18.1 shows you some of the markers that we have been using in the past. Previously we've discussed enzyme CK and specifically the isoenzyme function CK and B. That's specifically for cardiac tissue. We're also going to discuss myoglobin and the troponins. And this shows you a little bit about the time when they are beginning to rise following injury, when they reach their optimum rise, and when they begin to return to normal days. There's a significant difference. So we don't usually use one specific cardiac marker. We use multiple. First we'll discuss the troponins. There are three subunits, I, T, and C. Specifically I and T are related to cardiac tissue. In the skeletal tissue, isoforms troponin I and troponin T are formed. In the cardiac tissue, we have specifically one isoform of troponin I and a few of troponin T. We want to look into troponin I. It is considered to regulate the striated muscle contractions of the heart. It does have three isoforms. The cardiac form is never expressed in skeletal muscle, and this makes it a key marker for cardiac injury. It is elevated, begins to rise 4 to 6 hours following the myocardial infarct. We can possibly have false results for our troponin I assay, and this box in the textbook lists several of them. CK isoenzyme, specifically the MB, we refer to the enzyme rupture, but we do want to note that it does CK-MB or CK2 rises 4 to 6 hours following myocardial infarct and returns back to its baseline within 48 hours. Myoglobin is presented in the muscle and it is excreted in urine, making it very easy access for. It is definitely increased in cardiac damage, but also in several other conditions. The advantages of myoglobin detection is the testing is high sensitivity, and it does rise almost immediately following the infarct, so it's good for early detection. However, the disadvantages are that it's rapidly cleared after the damage. This graphic, which is in your textbook, will show you the different I and troponin T, along with total CK and CKMB and myoglobin. And what we're interested in on a timetable show us how they all begin to rise, and some peak earlier than others, and then some of them stay elevated longer, and then they begin to dissipate. Obviously, this one would be a great initial marker, and this is your myoglobin, and as it dissipates, talking about first day. Often patients do not present to the ER until the following day, so myoglobin would have already been reduced. Let's compare the troponin T, troponin I, and the MB fractions. As we can see, we're going up much higher with troponin T and C, so they seem to be elevated sooner and higher than CK and B, make it better to be using. And then you can see how troponin I has reduced faster than troponin C. But we're talking about 3 days here. When we're talking about heart function, other biomarkers that we might be interested in are elements that are released from the heart during normal hemostasis, and then some that are produced elsewhere that will act upon the heart, and then biomarkers that are released in response to the tissue damage, such as the ones we have just discussed for myocardial infarct. Congestive heart failure. Often patients have elevated jugular and venous pressure with an irregular heartbeat, and they may show edema or signs of volume overload. They may have defects in the heart itself, size-wise, shortness of breath. They are tired and having heart palpitations. One naturally occurring protein is the natriuretic peptide, which we discussed previously. It is secreted specifically by the left ventricle as the body is trying to fight against this volume overload and hypertension. Therefore, it would make an excellent marker. It's used to regulate your fluid volume, so it's going to dilate your blood vessels. It's going to act upon your water and fluid level with your electrolytes, and it's going to affect some other hormones. This is an overview of the biochemical formation of BNP, and BNP that we began to test at first is down here, but if we go back, the precursor pro-BNP we found to be a good source to be testing, and we've gone even further up. Some places will test for pro-BNP, some will test for the N-terminal pro-BNP or just the BNP. The N-terminal pro-BNP is higher in the plasma with certain patient conditions. If it is elevated, it is very indicative of heart failure, and so it can provide information on the level of severity. Another biomarker is C-reactive protein that we've also talked about. It is non-specific, but it has been linked to congestive cardiovascular disease. But there again, it is non-specific. We have began to measure it as a high sensitivity test. will give us a little more information. Cardiac ischemia is where there is an imbalance in the oxygen supply, and so the heart is having trouble performing its job. Ischemia markers that we currently test are some of our troponins, a albumin cobalt binding test, and an ischemia modified albumin. Ischemia modified albumin is produced when the albumin comes in contact with this tissue. The N-terminal of this albumin is changed through, say, chemical reactions. It is produced continually, so it is something that is helpful to monitor. And just as another refresher, going back to the lipids, the ApoB 100 is used for risk assessment for congestive heart disease, and specifically our lipoprotein A that's bound to this ApoB100, that it acts as LDL and plasminogen. So it plays a role in arterial sclerosis, mostly because it is competing with plasminogen for binding sites to interfere with clot formation. There's another fraction called the platelet activating factor that we have began to measure, and it's usually used along with additional testing. We would want to also measure our LDL and possibly the high sensitivity CRP. Point of care is rapidly becoming an asset in our ERs because we can get diagnosis immediately. The lab still has to oversee it and follow the regulations, so the lab is responsible ultimately for monitoring and performance of these analyzers. But even if it's performed in the laboratory, they are performed on whole blood very quickly, and so they do create great turnaround times. This chart is in your textbook, and I just broke it down out of the chart formation into a list to help you see the inflammatory process. Congestive heart disease risk factors are obviously our lifestyle, where we sort of tie this into our metabolic syndrome. When we have a high body mass, we have sedentary lifestyle, smoking with elevated blood pressure, and family history, our risk goes up. We can work on some of these assessments with our lipid control and diabetes mellitus. Another element that is not in your textbook is homocysteine. It is an amino acid in the blood, and it is usually an impaired enzyme activity disease associated with vitamin B complex, folic acid. We do measure B12 and folic acid in the laboratory regularly. We will have, if we have a low vitamin B12, we will have elevated homocysteine levels. Increased homocysteine levels promote plaque formation.